Uh, Thank you for everyone who is attending the Advisory Council meeting this afternoon. I'm going to invite my colleague, Melanie Cavalier, to provide an operations announcement, and then we'll continue forward. Melanie.
Okay, thank you. So good evening, everyone. And we would like to remind you the meeting's being recorded. So in the event that this meeting is hacked, please hang up immediately. And then I will send you an email through the MDPCP mailbox with a new meeting link that would allow you to log back in. The recording will be made available to the public. Please contact Anena or Melanie, and you have our cell phone numbers, or you can send us a chat message if you're having any technical issues. So you can mute and unmute yourself using the small button at the bottom of your screen that looks like a microphone. Please remain on mute when you're not speaking to reduce the background noise. Staff may mute you if there's a lot of background noise coming from your line, but you're always able to unmute yourself. Please announce yourself when speaking. So everyone is free to speak throughout the meeting. Since there are a lot of people, we like to sequence speakers when possible. So this technology does now have a raise hand function. So we're going to try to use that this evening. You're also welcome to still continue to hold up your, and we'll watch for that, but we're going to try to use the raise hand as well. So I think that's all I have. I'll turn it back to David for the next steps.
Wonderful. Thank you, Melanie. Again, good afternoon, everyone. Let me just read out loud the names of the people that have joined. And if I missed someone, please let us know that as well. We have Dr. Berenson, Kathy Chapman, Will Daniel, Dr. Haft, Kevin Hayes, Debbie Kuchka-Craig, Dr. Pham, Gene Ransom, Dr. Reedman, Scott Rose, and Bob Atlas. If there's anyone who is on from the council that I haven't announced your name, please signify that at this point. Okay. Otherwise, I would turn this over to Dr. Reedman for a couple opening remarks, and then we'll turn to Dr. Haft.
Thanks, David, and welcome to everybody. Thanks again for taking your time on a Tuesday evening. I know everybody's schedule is as hectic as mine is, so we'll try to be consistent with our time and finish the meeting on time. I'm not going to say a lot right this second. I have a couple of things I want to say a little bit later on, so I'm going to just really turn it back over to David and Dr. Haft for our opening discussion, and then I'll have a little bit more to say in a few minutes.
Okay. Welcome, Dr. Okiki. Dr. Haft.
Thank you, David. Thank you, Michael. And thank you to the Advisory Council members for joining us again this evening. And I think the good news here is that we successfully got through a Thanksgiving holiday that was unique for all of us. And now we're looking at really the last several weeks in this deliberation before we produce a suggested document for track 3 to our colleagues at CMMI for their consideration and review in the months to follow. I want to thank you all for everything that you've done so far. I think we've made great progress in looking very carefully at primary care first and modeling around that, making some very important policy indications that follow the stakeholders' guidance and from the Advisory Council. And I think tonight we'll move forward with making more of those policy guidance statements and be able to present those as soon as tomorrow to our colleagues at CMMI. We'll be meeting again with them and reviewing the progress that's been made by the council so far. I think there are a few large outstanding items, and perhaps we can touch on those, and certainly we'll touch on those this evening. One of them will be related to the presentation done by H-Metrics, Audrey Spader, on the per beneficiary per month modeling to look at where we hope or intend to have the investment made in terms of a level of a general average level of per beneficiary per month, modeling that based on where we've been in the past for fee-for-service, moving forward to value-based payments, and where we hope to move in terms of population-based payments. So we'll be able to reflect on that. And I would like to also get at least a preliminary sense this evening so that we can pass on some information to our colleagues at CMMI tomorrow about a direction that we would like to see this track 3 go in regard to the performance adjustment. We looked at in the weeks previous at the primary care first performance-based adjustment and found it, I think, resoundingly to be complex, overly complex, and not directed in the same way that we had hoped that this program would adjust performance in alignment with the state's integrated health improvement strategy and in alignment with meaningful goals for providers, meaningful and achievable goals for providers. So as a pure straw man model, we presented in a mailing earlier, either today or yesterday, to advisory council members an alternative that tracks more closely along the lines of what we're currently doing in MDPCP in terms of using various weighted measures based on their impact and their achievability, just as a discussion point this evening. So if we can get some initial discussion on that and the work and review the work that H-Metrics has modeled, I think we'll have accomplished, again, an enormous amount for this evening. But more than that, I just want to again thank everyone for your thoughtful comments and your input on every aspect of this track 3 as we try and create something together that will be meaningful and actionable and help build a strong primary care base in Maryland that will be sustainable over years and decades to come. So with that, I'll end my comments.
Thank you, Dr. Haff. And before we turn to the H-Metrics team, just for my team, I believe Alana still may be having some connectivity intermittent challenges today. So if somebody else could be ready to bring up the documents in the event we do lose Alana, and that would be great. I don't know if Ben, if you had any comments you wanted to make before we get started, or you would like us to proceed at this point.
No, I think everyone's time is precious, and they're anxious to see these latest results. So let's get going right away.
Okay, thank you. Audrey, are you keying up the slides, or is it on our end here?
I think Alana generally pulls it up, but there you go.
And you'll let us know when to proceed.
Yep.
And welcome, Scott Berkowitz. Dr. Berkowitz, good afternoon. Please proceed.
Great. Thank you, everybody. Good evening. Thanks for having us again to present some additional information with you. Just as a forewarning, I too am having some minor technical issues. So if I drop off audio, I will be right back in just a second. So please bear with me and apologize for that in advance. So we actually only want to share one slide with you tonight. So if we can go to slide, I believe it's slide 2. The purpose of our presentation today is not to present new results or not to present new modeling. Rather, what we're doing is that we've taken all of the existing results that we've had to date and changed the perspective on it, changed the vantage point of it. So rather than talking about overall program spend and what the impact will be for our model track 3 relative to track 2 spending, we have converted all of the various models into a per member per month so that we're looking at a apples to apples comparison. So when you look at the care management fees plus the E&M services that are included in the flat fee, what is the total per member per month payment that a practice would expect once factoring in beneficiary cost sharing and Medicare payment? So this allows all models to kind of sit on the same playing field, and you know exactly kind of what the relative impact is. This request, I believe, actually came from CMS, where they have asked the PMO to present the results in a per member per month fashion. So we've gone ahead and pulled this together. We do plan on sharing these results with them tomorrow during tomorrow's meeting with them. The one caveat is that the results that I'm going to share with you today include beneficiary cost sharing, because we are presenting from the perspective of the practice. What is the practice revenue going to be for these various models on a per member per month basis? Our discussion with CMMI will focus more on the Medicare outlay side of it. So to start from the top with some methodology, we have we're presenting four different models, but 5 different permutations of them. We're presenting a fee-for-service only model, which is what the per member per month spending would be absent of any care management program, just in a fee-for-service world. We also present results for the primary care first model, exactly as written according to their methodology. We also have, I know when it gets refreshed, you'll see results for track 3 under our 2 different permutations, one being a practice group model and one being our beneficiary group model. And the direction that we've been going in the last few weeks is towards the beneficiary group model, but wanted to also make sure to provide practice group for purpose of comparison. And last is number 4 at the bottom. We're sharing our track 2 results. So this is track 2 current MDPCP per member per month. Okay, so we've broken down our per member per month into 2 main categories. We have our CMF and our PBP per member per month, and we have our E&M per member per month. Our CMF or PBP per member per month is just the monthly management fees for each of the respective programs. We are assuming that beneficiaries are enrolled for the full 12 months, and the per member per month or the PBP or the CMF is specific to the program. So for PCF and for track 3, it's the per beneficiary per month as indicated under PCF, whereas we have the care management fees under track 2 for that model. For the E&M per member per month, we're looking at either a fee-for-service structure, or we're looking at the flat fee payments, GPCI adjusted, and accounting for beneficiary cost sharing. Across all of these models, the E&M per member per month is limited to the same 39 codes. It's the same 39 codes that are included in the flat fee under PCF. So this is truly an apples to apples comparison across all of the various models. The only thing that differs is the way that beneficiary cost sharing is handled. So for example, in the fee-for-service model, it's as simple as that. It's fee-for-service Medicare, which it would be the same as for track 2. Under PCF, in both of the track 3 permutations, it is the flat fee plus beneficiary cost sharing for each of the individual E&M services that are provided on that claim. But I think what the important part here is that it is the exact same 39 codes in all models. We're using 2019 utilization inflated to 2021 payment rates. And in order to make sure we're calculating per member per month payments appropriately, we are using the total member months that a beneficiary was eligible in 2019 or enrolled in Medicare for Part A and Part B. That just serves as our denominator. Just to reground us, we're looking only at track 2 practices. There's 122 of them, and 99,000 beneficiaries, which represent the attributed beneficiaries as of Q3 2020. We'll get to this last point in just a second. Now let's jump down to the table, and I can just walk you through the results that we found. So under a fee-for-service model only, there is no CMF or PBP per member per month. There is no management fee structure when there is no program. So we estimate that those 39 E&M services have a per member per month payment of $39.68. That's effectively our benchmark, or kind of our control total for current law. The PCF model, we calculate a per member per month payment of the CMF and PBP of about $30, with E&M payments of $24.39 for a total of $54. And just slightly higher than that is our track 3 modeling of our practice group model. The only difference between Model 2 and Model 3A is the flat fee that we apply. So under PCF, you may recall the flat fee was described as $40.82, which was a 2018 payment rate. We have inflated that to $2021, which is $54.20. You'll see that in bold in the assumptions column. When we did our track 3 modeling to look at the practice group, we have adjusted that even further to account for multiple E&M services that are on a claim, and have inflated that by 13%. So we have a flat fee of $62. You'll see between 2 and 3A, the only difference is the E&M per member per month, and that is fully attributed to the difference in the flat fee amount. The Track 3 beneficiary group model still continues to use that $62 flat fee, but it does have a higher CMF or PVP per member per month amount. So rather than the practice group, the per member per month of $29.76 in practice group, when we switch to the beneficiary group model, that increases to $45.97 for a total of $72.35 for a total per member per month. And last, for purpose of comparison, our Track 2 results. This was used as our benchmark or our comparison through the analyses you've seen to date with us. We have a total of $73.70. It's the CMF payment per member per month plus a fee for service E&M payment, as there is no flat fee in Track 2. I do want to make just one caveat here that we have noted at the bottom, is that we have not adjusted our Track 2 E&M payments to account for the 10% inflation for the CPCP payments. We actually worked through a lot of the math, and we find that increase to be quite modest once you factor in all of the kind of the permutations and the selections of the various practices. But just to note that our E&M per member per month is slightly understated. We estimate probably 2 to 4%. So if that were to be incorporated, the total per member per month in the E&M per member per month would be slightly higher. So I think at this point we can maybe open it up for questions or discussions just about the relative per member per month in these models. And I think I would just conclude with the sentiment that this is the modeling we have to date. This doesn't necessarily need to reflect the levels that the policy needs to be kind of submitted at. And Dr. Haft, I'm sure you can talk more about that, is we're looking at big picture structure, and we're looking at kind of the elements of the model. We do have ample opportunity to kind of finesse the amounts or finesse the inputs to derive alternative per member per month payments.
So before the group gets started, Dr. Reedman, is this a good place for you to tee up sort of the philosophical approach? Because Audrey mentioned that there's a policy element here. There's an element of understanding the data, but then there's also a policy element that probably painting that picture, at least in prepping for discussion, might be useful. And I think you're muted, Dr. Reedman.
There we go. And that was me, not you, Melanie. Yeah, this is a perfect time, David. Thanks. So from the philosophical standpoint, first of all, I got to say I've been very happy with the presentations, all the presentations that Audrey's given, and I think it's really helped us to focus our thoughts. It certainly helped me to focus my thoughts. In the bigger picture, and I think we need to talk about the numbers, and we'll open it back up to the floor in a minute. But the big picture to me is that, and we talked about this on numerous occasions in different ways, but the goal here has always been to make an investment in primary care. I'm getting feedback from somewhere. Is that coming from me? Do you know? Okay.
I think it's actually coming from you. We're not seeing it from others at this step.
Okay. It's better now. So great. So I'd like to, I like to give a little story. So I'll kind of give a premise to this, but I've been doing this. I've been practicing. I've been in medicine for 40 years, and I've been in private practice for 32 years now. And certainly seen a lot of changes from the private, the HMO days to to full fee-for-service days to where we are with population health now. Originally, when I started in practice, I would see an average of about 40 patients a day. My notes were done. I think I did the same quality of medicine as I do now. Back then, I certainly have more experience now, but I was averaging about 40 patients a day, and most of primary care physicians were seeing in the 30 patients a day or so. And I'd write my notes, and they would be good medical notes. I would circle a time frame that I saw the patient for 15 minutes, and I'd write down that they had a sinus infection or they had a heart attack or whatever it was, and my notes were good medical legally. And I think I practiced very good medicine at the time. Over the years, I actually now see about 27, 28 patients a day. That's a little bit on the high side for most primary care physicians still. Most of my colleagues are down into the low 20s because, one, the patients have become much more complicated, and obviously that takes more time, and that's not necessarily a bad thing. But the other thing is that I spend an average of about 2.5 to 3 hours per day I can't just write down a diagnosis of high blood pressure, whatever. I've got to find in the chart that it was high blood pressure and which high blood pressure was, and I have to code it appropriately, make sure I do my coding appropriately for reimbursement and for documentation. I have to document not just the positives on the patient, but all the negatives on the patients in order for coding. And in addition, I used to write a referral, and I'd tell someone, go get an x-ray of your chest and go see the gastroenterologist for your colonoscopy. And I give them a piece of paper. And now I have to fill out a form for both of those. In addition, I have to link that form to a diagnosis for every one of those patients. I have to have an appropriate diagnosis for each one of those labs I order, et cetera. The point is that as an average, and I'm on the low end, I'm spending about 2.5 hours, maybe up to 3 a day, just in documenting for patients, which takes away from patient care, takes away from my interactions with the patients. I still need to do all the other stuff that I've always done for patient care, but I'm seeing a lot less patients. So I think it's really important as we look at where primary care physicians are, and we look at how to recruit new primary care physicians and what primary care physicians want to do. It worries me, and it has worried me forever, that if I'm seeing 15 less patients a day, who's seeing them? Well, we obviously, and I think everybody on this committee knows, we need more primary care physicians. When we talk about recruiting them, and we talk about reimbursement, we talk about the responsibility and the paperwork part of it, and the risk part of it, which we keep talking about in this committee, which I think is really important. I think we have to keep all that in mind, that's a big part of where primary care is. So if we're going to make a true investment in primary care, I think that we need to, one, make that investment on primary care, not put the primary care physicians at significantly more risk for what they're doing. I think that we've historically been the lowest paid physicians in the tier for what we do, especially. I think that more appropriate reimbursement for the primary care physicians should be part of our philosophical discussion. Part of that is that if we're talking about reducing our fees, our flat fees from where they are now, and putting us at more risk for making the same or a little bit more than we do now, I don't think is appropriate. So I think that we need to have some at least reasonable increase in our base fees. I think that there needs to be, we had about 1.5 full-time equivalent staff for each provider, and we're up to about 3 right now. So we have extremely high overhead costs for what we do. And part of that's because we have referral people now that have to do forms, and we have coding people, and we have clinical care coordinators and all that. So there's a significant cost that wasn't there 25, 30 years ago to doing medicine. So in addition to the fact that we see less patients, there's a significant cost, a higher cost of what we do, just because of the bureaucracy of it and because of the care that we need to provide and the complexity of medicine. So on top of an increase into the base fees, I think that there needs to be some kind of management fee, or at least built into this, something to cover some of those overhead costs. So that would be my second component. And my recommendation and my goal would be to, if we had a little bit higher reimbursement for what we do, some extra to cover the extra cost, which right now we have a care management fee. And the third component is, we keep talking about risk. I think that's reasonable. I think that the primary care physicians and providers that are doing primary care, if we're all in this doing the same thing, there are always certain patients, physicians out there, that may be looking to see 10 extra patients a day so they can get that extra whatever it is for the fee for service, but that's not what most of us do. We see our patients and we do the best we can. And our goal isn't to see more patients. In fact, if we see more patients, it's only because we feel like they need to be seen that day for whatever the issue is and work them in. So I think if there's risk, that risk should be on top of something to cover cost, an increase or an investment in primary care. And then the risk is if we are able to reduce cost, then there's an incentive to reduce costs and to do all the things we need for population health. But I think that I've heard a couple of times that we need to give a lower, lower base fee, that we need to discourage fee for service visits and individual, and physicians trying to work to see more patients instead of less patients. I think if we make the reimbursement for the patients reasonable, none of us are seeing more, we're all seeing less. The reimbursement should be appropriate for that. I think if we look at those three components of investment in primary care, covering some of the extra overhead, and an incentive to reduce the cost, that we would have a program that would be worthwhile. It would encourage primary care participation over time. The physicians would be content with that. It would help offset some of the frustrations that we have from the paperwork we have to do and the administrative burden that we have to do. And that, again, literally 2.5 to 3 hours a day of just documenting and doing paperwork. So I'm going to leave my spiel at that point. But I just like everybody to keep that in mind as we go through these numbers. I think these numbers are a good basis. I think that there was a slide that I'm not going to ask you this, David, but there's a slide that Chad had sent out last night late. I don't know if we have that in our presentation, but it talked about, and I think Dr. Berenson had brought this up before, about the cost of doing primary care too. And I think that we really need to look at if we're being paid $72.35 per member per month, but if our cost of doing that is $71.35, then I think that's something we have to keep in mind too. It's a cost. There's a cost of doing medicine, and we have to be very careful that these numbers are above that cost with all the things I mentioned. So I'm going to stop talking then. I'll throw it open to the committee to make comments on either what I said or certainly what Audrey said, and we'll go from there.
Okay, thank you, Dr. Reedman. So consistent with Dr. Reedman's responses, comments, questions to the data or to the guidance provided by Dr. Reedman. And I would like to reach out to Dr. Berenson to get his thoughts.
Well, I agree with basically with Dr. Reedman's presentation. To just clarify, what I had raised a number of sessions ago was specific to the fee-for-service visit, which is that there are billing costs associated with collecting that, and when it used to be $40, and the cost, which the best I can find is probably $20 or $25 just for administering the claim. We're now, it looks like in 3A and 3B, we're getting that up so that it's now sort of a 3-to-1 ratio of revenue to the billing costs. It's approaching, I think, something more reasonable. I don't know that we have focused on this before. Does PCF convert the co-insurance into a co-payment at the time of service for the fixed fee for the visit? That would reduce billing costs substantially, I would assume, and I'm not sure what's assumed. Does it still have to, I guess if most people have supplemental, it still has to go out. If it's Medicare, it still has to go out, right? So you're not saving. I mean, it would be a real advantage if we could somehow get it so that it was a cash in the office or a Visa card in the office and reduce the whole billing cost there, but I'm not sure how that could be operationalized. And I just had one very small question. I don't think this is a dramatic one, but I'm just curious for Audrey. The assumptions that went into calculating the PMPMs on utilization, was it a national utilization adjusted for GIPSY for Maryland, or was it Maryland utilization?
It's the practice-specific utilization for those physicians and for those beneficiaries. So we're really staying inclusive to the participating practices for those attributed beneficiaries.
So it even involves, I don't even know how many Medicare gypsies there are from Maryland, but it would be relevant to that particular practice's geographic
Absolutely.
area. Okay.
Yep, they're all gypsy adjusted.
Dr. Barr?
Oh, thanks. Sorry I joined late. I agree with Dr. Reedman extensively in terms of the need to support primary care. Obviously, going back to my days at the American College of Physicians, that's what we were working towards in the PCMH, so this is part of that. I think there's another transition that primary care and all physicians will have to go through going forward when they change the evaluation and management documentation requirements. And I think that's something else that practices and will need to adjust to. So I'm not saying it's going to be easier, just be different. And I think we need to recognize the work involved in doing all that. So nothing more to add other than I support what Dr. Reedman said in terms of the challenges and the need to support primary care.
Yeah, it sort of gets to Dr. Reedman's point about a management fee when you position it that way, Dr. Barr. So Dr. Okiki, comments?
Yeah, I will also like to commend Dr. Reedman for what he said. I mean, his passion was so palpable, and I think it kind of speaks to all of us who are clinicians in general, and for those of us who are on the other side of the aisle to really see what can we continue to do together collaboratively to make it better for the primary care workforce. I think the one thing I wanted to ask Audrey, when we look at the total CMF and PBP, PMPM, does that take into account that the clawback would include that total PMPM versus just the PBP as currently is with track 2?
That's a great question. We are not modeling. Ooh, I hear an echo on myself.
Dr. Okiki, will mute you.
Is that better?
Yes.
Okay. We do not include any recoupment assumptions in our modeling. So we're not looking at leakage. We're not looking at recoupment. We're also not looking at the MIPS and sequestration adjustments, which are, those are kind of off to the side. We are assuming that all beneficiaries remain engaged in the program for all 12 months. So there's no recoupment there, and there's no leakage that would cause a clawback of any kind. You're muted again.
The only reason I asked is that we're looking at it only from what's coming in terms of payment, without also considering that there are the other unknown factors of how operationally and effectively the primary care transformation is currently now and what it will be in the future and all the confounding factors. Then again, I think understanding what's at risk becomes even more important, because if you see track 2 is slightly higher total PMPM than what is at least what we're favoring track 3B, right? And I think that was just something I wanted us to keep in mind if we could have more clarity on before we pick one or the other, but just my thought. Thank you.
Dr. Pham. Okay.
I don't have anything to add.
Okay. Jean, any thoughts here?
I agree with what Dr. Reedman and the other physicians have said. I think they've encapsulated it quite well.
Okay, very good. Thank you. Other comments from individuals that haven't weighed in yet? Debbie?
You mentioned that our colleagues at CMS asked for this, correct? So are they, that's where my head is. I didn't disagree with anything that Dr. Reedman said. I think a lot of primary care physicians would feel that way. I don't know what our options here in terms of their end game. They want more at risk. And as was just pointed out, the difference between line 4 and 3B does show more at risk. But, if primary care first is what they had in mind, do they have a number? Do you think they have a PMPM number or it in mind to make a track 3 acceptable?
Dr. Hatt.
So I think those are all, first, thank you, Dr. Reedman, for, I think it was very heartfelt and accurate depiction of primary care's progression over the last 40 years of your practice. But you don't look nearly that old, I would have to tell you that. But I think it's a realistic picture of where primary care is currently. We've had over the last couple of days a meeting with the Primary Care Coalition talking about many of these same issues on a national level, and I think we're seeing that primary care is, as Dr. Reedman pointed out, the lowest paid of all of the medical specialties, and the payment proportionately has been declining year over year, not growing, even in the light of, as Dr. Reedman again painted a very clear picture of increasing responsibilities. I think he limited the responsibilities to things that were administrative responsibilities, which are clearly growing, and I think have grown for everyone, but disproportionately for those who see primary care patients. I think what wasn't included, I think in his description, was really what we anticipate now, what we know based on studies, and what we know based on polling individuals, what we know based on the best science that's available of what we need to do in order to provide comprehensive care to our patients across the board. We know that now is no longer simply a doctor and his wife, who is the billing manager and the nurse in a primary care office. It's now team-based care. And in that regard, even as early as 2007, a much younger Dr. Berenson wrote an article in the Journal of General Internal Medicine that described team-based care and what the comprehensive payments would be required to provide that comprehensive team-based care on the average. And in 2020 dollars, that number that, and he is probably going to fillet me for mentioning this because I probably will not get it right, but I believe it was $66 then, which would be in 2020 dollars would be $80 and change. And in his 2007 view, together with Dr. Schellenbaum and Gorel and others, they included a number of people in that group that would be supporting these patients, but not everyone that we see that we use now in advanced primary care. So probably to provide the same kind of service that we provide now in MDPCP, with all of the cadre and of folks who contribute in as this team-based care, including behavioral health integration and addressing social determinants of health, the cost would even be higher than that $80. I know that we've taken a look at what if you simply said primary care should not be 5% of the total spend, not 5 cents out of every dollar that is spent in healthcare shouldn't be primary care. Others have said it should be at least 10 cents per dollar. If we did that in this model, it would be about $108 per beneficiary per month equivalent. So either of those, if you took a 10% hurdle, or if you said, let's just use the work that's in the literature already and move it forward, it would be an $80 hurdle. All of the models that we have now, fee for service, primary care first, track 3, either iteration, or track 2, are all, as Dr. Reedman indicated, are all still less than what you need to really do a good job. And I would suggest that if we have an opportunity now to say what we want to do is really do a good job taking care of our primary care patients and make this investment in primary care so that we can do that and do it in a way that's meaningful. And we should take those kinds of steps, and we should make those policy statements. I'm not saying where that number is, but I think it should track along our best evidence and our best intuition for what it takes to get the job done, not what it does to go back to the hamster wheel of churning to have to see more patients to meet those minimum requirements, because you start cutting those patients short in terms of care. And what it actually costs to to provide good, high-value, comprehensive primary care. And that's where our policy number should land. I think that's where the healthy discussion comes from here. And I think that's what to get to the answer of the question, that's what CMMI wants to know. They want to know if it's not fee for service, what is it? We may have disagreements. They may have a different budget in mind, although in our context, our budget is the state's budget, and it's lumped together, as we know, together with Part A and Part B, and we're all in this together. And we need to hit certain targets. So that fact is not lost on us. But what is the number that we need to put on the primary care side to get us to those targets and to achieve the goal of actually improving the health of patients and make this a sustainable program? I think that's the policy issue that we have before us.
So, Dr. Haft, a follow-up question, and then Willem Daniels. In the discussion with CMMI that's coming up, could you talk a little bit more about, is the strategy to present a particular element from the model, and then point out, as Dr. Reedman had suggested, and I believe you did artfully so of work Dr. Berenson and others have done, that the real number should be somewhere else, and what that estimate might be, and to give them a heads up in terms of what the advisory council may be thinking? Or is your strategy something other?
So I think it's to say that where we are on track 2 now is the number that's here on an average per beneficiary per month. And this is taking into account, again, both that part that would be given as a flat fee, and that part which would be care management fee or population-based fee, whatever term you want to use for that, but that per beneficiary per month risk stratified number. The aggregate, for at least 2 reasons, should be somewhat north of what that $73 is. For one reason is that if we present something to practices that says on the average, what we're going to be doing is not increasing the amount of investment that's made, but we're either decreasing it or making it flat, there would be not a big incentive to then put all of that money, or the vast majority of that money, at risk, at any risk. It would be contrary to their best interest. It would defy the common economics view of acting in everyone's best interest. So that would be probably a non-starter for that reason. But for the second reason, that it would also fall somewhat short of what we feel is probably the adequate investment on the average, risk stratified, in a mixture of both flat fee and population-based payment to get the job done. So how much higher that would be than that, I think, is a question that we'd have to negotiate. But I would think that we would start from the point that it should be somewhat higher than track 2 and approaching some mark, as in that we could come up with as a reasonable amount for the overall budget, and then work backwards in terms of, as Audrey said, making both the flat fee and the risk stratified numbers fit so that it doesn't disadvantage any individual practices any more than, or neither disadvantages nor advantages anyone any more than what they already are seeing. So to avoid dramatic shifts in the overall payments. That would be the strategy.
Thank you. Will?
Yes, thank you, David. David, can you hear me?
We can. Please proceed.
So I would agree with Dr. Reedman, and I think other members of the council. I think that primary care definitely deserves additional investment and is critical to making the rest of the system work. I'm a little concerned. I think we've spent a lot of time talking about how much money primary care should get paid. And I think that would be very appropriate conversation in the context of the fee schedule and other aspects of Medicare policy. I think we're going to be evaluated by CMMI, and that evaluation will include some assessment of the primary care program, and they will make an assessment as to whether it's, quote, working or not. And I'm concerned that we don't have a good idea of what those criteria are, and we don't know how we're doing relative to those criteria. And I don't know that we have tailored the investment to ensure that we're succeeding or increasing our probability of success under those criteria. And so I think that's worthy of some additional thought, especially once we start seeing the evaluations come out of CMMI.
Thank you, Will. Dr. Haft and then Dr. Pham. Dr. Haft, any insight to Will's comment?
No, thank you for the comments, but I would say the goal was to provide broad under the total cost of care model for at least for primary care, was to provide broad healthcare transformation across the state, and be able to also, as a result of that, to reduce avoidable hospital and emergency department utilization. So in terms of the markers for that, we've, I think, done broad healthcare transformation across the state in so many ways, as pointed out in the annual report that was provided to all the advisory council members. The other issues related to reducing avoidable utilization, things that will take time to mature. That doesn't happen overnight, but we're, I think, fairly confident, and will likely want to include in the performance adjustments as we configure those and the incentive packages with this track 3, a very focused attention on exactly what you're talking about, Will, which is how do we within this model incentivize those things that we desire for this program, and how do we report those, and how do we disincentivize failing to achieve those very focused goals. So I think that's the other part of this. This is the investment strategy, and I believe what you're talking about is, and then how do we have the accountability that the investment is achieving those goals of healthcare transformation, behavioral health integration, meeting the goals of the state integrated health improvement strategy, and other things. And I think that's what happens on the incentive side.
So thank you, Dr. Haft. Dr. Pham, and then Will, your hand is still up, so there may be a response to both Dr. Pham and Dr. Haft. Oh, there's your hand. So, Dr. Pham.
I guess I would encourage us to draw back out, take us a few steps back from the trees that we're staring at, and consider that Maryland is in an extremely privileged position. No other state is in such a relationship with CMS where it can exert multiple levers over the system as a whole in order to arrive at an evaluation result that the agency would look favorably upon. I would also point out that given that we've been spending so much time talking about what a small proportion of total spend is accounted for by primary care, that asking this particular sub-experiment to generate savings or even budget neutrality is a fool's errand. If you're going to do that, then you're not really investing in primary care transformation or system transformation, for that matter. In terms of where there is give in the total spend, that would be an efficient source of savings, that would be a scaled source of savings as opposed to in primary care. Well, you have lots and lots of options. There are inpatient prices, there are outpatient procedural prices, there are imaging prices. There's a ton of other sources of spending in the system that Maryland, in its privileged position, could take a look at, rather than trying to sub-segment these individual sectors and getting each of them to a certain evaluation outcome. You could look at that overall net big picture, and I think just be really creative about how you go about that. I understand that that's not the work of this advisory council, but I think we tend to lose sight of that because we're in our little primary care bubble here, and it's just, remember, 7% of what is going on out there.
Yeah, good point. I think Dr. Berenson has a response or a comment along those lines. And Dr. Berenson, you're muted.
Yep, it takes me a while to react. A couple of comments about the percentage of spend, which I think we just have to be clear about. This is a Medicare program, and in Medicare, the spend is 2.5% for primary care. Medicare has proportionally more hospitalizations, nursing home admissions, durable medical equipment. You can go down the line much more so than does commercial insurance or the portion of Medicaid that's treating moms and kids. So we are only at 2.5%, and that, to me, doesn't pass the face validity test with an aging population with multiple chronic conditions. So I think a good case can be made there. And then there is data which I actually remember much better than what Howard referred to that I helped produce, which documents that primary care physicians are actually at the second lowest on the total payment. Psychiatrists are below. The psychiatrists who actually do therapy do it out of insurance, and it's sort of a side issue. Primary care has been and continues to be the low specialty on the totem pole. So when we sort of demonstrated that if Medicare were the only payer, in other words, all commercial insurers and Medicaid, we're all using the Medicare fee schedule. There are some specialties that for every hour worked would make 2.5 times what primary care is making. And obviously there would be significant outliers who are making much more than that. I think that is one of the arguments to be made. It's only 2.5%, and it is by any rational policy rationale under investment in primary care. On the other hand, the numbers of, trying to get to 10% or 11%, which has been advocated as a system goal, isn't supposed to happen just by raising incomes for the existing cohort of primary care physicians. That really, a good part of that has to happen by producing more primary care physicians. We're having major shortages of physicians and nurse practitioners, and to get to any reasonable goal as a percentage of total spend, it can't just be that we're increasing incomes for the existing number of primary care physicians. So if I were sitting at CMMI, I would push back at that argument a little bit, but I think there are arguments that can be made. I can't remember the number that Howard was quoting. My part of that paper was to basically argue that you can't convert fee-for-service into PMPM without recognizing that in a capitated world, you're doing many more things. And we outlined a lot of what those things were, and some of them have been captured in the fee schedule codes, but most of those cannot be done through fee schedule payments. And I would anticipate that the world of telehealth will be exploding tremendously. There'll be huge demands on primary care physicians for that. And that by itself, I think, could justify a substantial increase in the PMPM just to handle telehealth. So I think there's multi-factors that can be brought to bear on why it is that this experiment should go forward with a generous increase for primary care, probably north of what we've got here, but I think we're approaching it in the bottom two rows. And then the final thing that we talked about a number of times in the past is that the incentives in Maryland on primary care physicians are not primarily to reduce hospitalizations. The hospitals have those incentives to begin with. Primary care docs don't have a lot to do with hospitalizations, and it strikes me the real opportunity is referrals to specialists and specialist behavior. And if we can come up with some creative performance measures and incentives to decrease that, I think that would be where we ultimately have a payoff for seeing this.
Okay, thank you, Dr. Berenson. All good comments. Will Daniels. And if you're muted.
Can you hear me?
Yes, please proceed.
Thank you. So I think Dr. Pham, you made a very good argument for why the MDPCP program should not be evaluated on the basis of producing total cost of care savings, within its own subcomponent. I hope CMS agrees. I expect that CMS will look for, if they don't do that, they will look for other care transformation measures. And I think that we need to know, will they evaluate MDPCP's effect on total cost of care savings? And if not, what else are they going to be looking at? And I think in the past, our experience with the HSCRC has been that when we're not very clear and have very clear agreement with CMS, they pick kind of crazy stuff and evaluate us on, right? So we, under the all-payer model, were evaluated on our impact on reducing obesity rates within the state of Maryland, which was not an emphasis of the all-payer model. And so we get these results back from CMMI saying you haven't had a significant impact on population health because of this measure. And I think we need to make sure that we have a very clear agreement with CMS on what measures will be used to evaluate us, and then make sure that we're tying the performance in the program to those measures. Because I think we have a lot of opportunity to do good with this program, but if we are not on the same page with the CMS evaluation, we could be in a problem later on.
Yeah, a good point. So, Dr. Berkowitz, we hadn't given you a chance to weigh in and comment here. Any thoughts thus far?
I just want to echo some of the comments that have been made earlier regarding Dr. Riemann's testimony. I think he was really spot on, both from the historical evolution, but I think his point also about future recruitment of primary care providers is also critical in understanding how they can be attracted and feel like they can be successful within this new model of care. So I think continuing to support that, and to Howard's point about not rocking the boat in terms of being able to sustain current efforts, I think are really going to be important.
Yes, thank you. And I wonder if Kathy Chapman, if you're able to weigh in from your perspective as a clinician.
I have to apologize. I got interrupted and I have missed some of the conversation, so I don't feel like I can really make any intelligent comments. Understood.
Thank you. So is there anyone else that hasn't had a chance to talk? Perhaps we could ask Kevin from the consumer perspective to weigh in here.
Yes, I have to agree that we've got to be talking about a higher PMPM than what we have under track 2. I mean, to ask these practices to take on the additional risk to play a meaningful role in reaching our goals for total cost of care and so on. I mean, we've got at a bare minimum, we've got to be talking about something above that $73.70. As to the issue of, well, okay, are we going to get value for that additional investment? We have accountability mechanisms built into this, or we intend to have accountability mechanisms built into this for total cost of care and other things, as we'll get to in a bit. And so I'm not worried at all about whether or not we're going to get value for that additional investment. I mean, it seems like there's a feedback loop built in here that provides us with that assurance. So I don't see what the problem is. Thank you.
Okay, thank you. So, Dr. Haft, Dr. Riemann, and Dr. Haft, I think we've tapped into everybody's comments who had thoughts here. Is it your sense that to sort of paraphrase what the takeaway is and the message that and Dr. Haft, how you will approach the meeting for tomorrow, and then the next question is, did we miss anything that the council really ought to weigh in on here? And we can start with Dr. Haft if that works.
So no, I think for this particular aspect, I think the comments were fairly uniform, and I don't think we missed anything. And I believe that to focus on Dr. Baronson's comments, that it is twofold. The investment in primary care should be both an investment so that each practice can do the amount of work that's necessary, given the bundle of work that now is not that needs to be done to achieve healthy outcomes with those patients. But it's also about making sure that we can pay attention to expanding the primary care workforce, because there's simply not enough primary care, and it is both the number of people in the workforce and the patients that they can take care of, as well as the rate per patient that will describe the total investment. Both those things need to be taken into account, and we need to have, I would say, parenthetically, sufficient incentives in the existing system to be attractive to young doctors as they're choosing what they want to do with their careers. Right now, we're not at the top, probably closer to the absolute bottom of that career selection for primary care, as evidenced by the fact that it's been decreasing over time relative to others. So I think those were good comments, and I'll pass the ball to others. But before we close tonight, I did want to spend a little bit of time, if we can, after this round, talking about the performance bonus adjustment.
Understood. Yes. So I would invite Dr. Riedman to weigh in here, and then perhaps we can turn it back. We can move on to the next agenda item, Dr. Riedman, if you're satisfied with where we've left off.
Sure. Thanks, David. And thanks for all the comments. I have others, but I will save them for later. There are other examples of where we are at primary care, but I think everybody on this committee understands the importance of primary care and what we do and the issues that are at hand. I think that, and Howard, correct me if I'm wrong, but if this committee can make some recommendations to CMS about the investment in primary care and what we see is appropriate, and I think that the numbers we have in front of us on the screen here are at least starting points. But my understanding is we don't need to come up with for right now with whether that's going to be $62 or $54.20, whatever. But if we come up with a basic concept and a philosophical conversation with CMS about where we think the program should be, that's kind of what we're looking at for this year. And if we can get an agreement, then we'd be able to modify and clarify exactly what these numbers should be sometime next year, if that's possible. So correct me if I'm wrong on that, or if there's a better way to approach it. I'll throw that open to you or Ben to maybe comment on.
So Michael, I think you're right. And just to frame that appropriately, give proper context again to the advisory council, what CMMI has asked us for is not specific numbers to bring to them by the end of the year, but rather policy decisions about what Track 3 should look like, and then what those policy decisions were based on, with as much backfill of data as possible to support the discussion about the policy decision. So I don't think it's going necessarily, and probably will not be, the actuarial accounting of what each level of beneficiary would get at this time, but rather kind of an overall picture of what the policy decision in terms of the overall investment and then other pieces of the model. And I would say that the ask originally was that that in the course of these 6 months, we started, I think maybe 5 or 6 months in July, that this council, together with the PMO and CMMI, would come up with a model of Track 3 that could be presented for clearance to start in 2023, and that it should look substantially like the design of the model for primary care first, that it would have at least the basic trappings of having a flat fee, a population-based payment, and a performance adjustment. So we've been working within that context, and now we're getting the details on policy pieces within that, such as it would deviate from the core level of primary care first. And it must deviate. The primary care first is designed to test something different than what we're testing here in Maryland. And what we're testing here in Maryland is a Maryland model. And what we do for the MDPCP track 3 has to fit into that context. So that's the work at hand.
Thank you, Dr. Haff. Dr. Reedman? Oh, and you're muted.
No, I was just wondering if Ben had any comments on that also.
Yeah, I think one of the points I would emphasize is that we put quite a bit of credibility in the advisory council. So this feedback to CMS is going to be important. But I also think that we shouldn't lose sight of, we need to carry something forward beyond PMPM should be more, which I think was universally argued, or the PMPM should be a lot more, that we put some increased accountability or explain a bit more of how what we're offering to CMS, given for not a lot of clarity on my part on why they may be very anchored on primary care first as being the starting point for what they think is appropriate. So I think we have to think about this in terms of what would be greater responsibility that can be offered as well. I like what Kevin said about that, and I also think we can't lose sight of becoming primary care involuted, that there's significant other opportunities for savings within the healthcare sector, particularly specialty care reimbursement, that we're not really touching on here, nor is it within the purview of this group to talk about it. But we do oftentimes get riveted on the only tools we have, which clearly primary care has come forward, but it's not the only savings opportunity we should be looking at.
Yeah, good point. Thanks, Ben. Dr. Haff, Dr. Reedman, I think we've concluded on this portion of the agenda for tonight, and would propose that the council, we move on to the performance-based adjustment. And I would ask Alana to bring that up on screen. And then Dr. Reedman, if you have some opening remarks, we can then forward to Dr. Haff.
No, I'm okay. Well, I'll turn it over to Howard. I think we're a little limited on time. I'd like to get through this tonight, so I don't have anything to add before Howard goes ahead and does his presentation.
Okay, Dr. Haff.
Thank you both. So this was an alternative. Doesn't need to be. This is how we wind up for a performance-based adjustment, but we'll start from assuming that we will have a performance-based adjustment in the model in order to be consistent with the framework of primary care first. And based on the discussions that we had several weeks ago, looking at the primary care first performance-based adjustment, it was my clear impression that the advisory council felt that it missed the mark in terms of what we're driving for in Maryland and being overly complex, both for the beyond the ability of providers to understand how it would influence, or it would not directly influence their behaviors, that the behaviors that would be influenced might be actually contrary to the goals of the Maryland model, and that it might, in effect, by how it's configured, might cause an egress of providers from the program and be contrary to our goal of having broad-based healthcare transformation across the state by driving eligible and qualified practices away from engagement with the MDPCP track 3. So there are many ways, an alternative to do that, the performance adjustment, and what was presented here to you, and we can talk through it. And if you haven't had a chance to read through it, I will just highlight it. It is designed to be just a simple way to do a performance-based adjustment, in which there would be a bundle, and presumably a small but very focused bundle of goals that providers would drive toward. They would be easily identified. They would be aligned with the state's goals, and they would be very actionable goals. That would be the performance goals themselves. They would be weighted according to the bundle, according to their ultimate impact and importance. And then the achievement of each of those goals would be standardized against some benchmark, national benchmark, to be fair and equitable. And providers would be judged based on their ability to achieve those goals. And then the aggregate achievement of those goals would be balanced against their total primary care payment, so that they would have essentially at risk an amount, an asymmetric downside compared to a larger symmetric upside, using the same ratio as in primary care first, if we choose to do that, but allowing for an annual adjustment in payments that would be a range that would be progressive over time, but not necessarily casting every one practice into the range of -10 to +50, knowing that when we surveyed practices, a third or more would not be willing to take a -10 to +50, and these were among them very good practices that said those ranges of putting all of my, or the vast majority of my Medicare revenue at risk for losing 10% of it was not something that would be acceptable to them. So they would likely exit the program. So allowing for a greater range of risk, but saying that both the incentive, the upside, the incentive, and the disincentive should still exist. I think that there's part of me personally that does not feel that risk is something that I would want to put our primary care practices up against. They are, if you wanted to look at it in one way, they are probably the poorest among us who stand, and whose ability to withstand risk is probably the least of all. But I think we would have a difficult time making that argument and still have it adhere to the broad brushstrokes of primary care first. So I think having a middle point, we're allowing a range of risk, much as what we see in the current CPC plus track 2 comprehensive primary care, where practices can choose to start lower and then move up over time. That it would follow that model. So this is one way to do that. I hope that it follows some basic guidelines of being simple, understandable, aligning with state goals, actionable, and standardized, and would be simple to administer. One, how do you do on your measures? And presumably we would have measures that are meaningful and the practices could follow along the way, so that they're not caught off guard, don't know how I'm doing until the end of a year or such. Have those measures be weighted appropriately, and have the step 3 just have them held accountable based on their performance within ranges. So that's basically the design. The details, again, we can talk about, but I would appreciate input from this very thoughtful and highly professional group about just an overall design. Wide open for suggestions.
Thank you, Dr. And Alana, can you scroll down the page a little bit? And Jean had a comment.
Yeah, I wanted to talk about risk, and I understand why we are where we are, but I think I share Howard's concerns, and maybe I'm even more concerned. Physicians, particularly primary care physicians, are not insurance companies. Forcing them to take large amounts of risk is not rational and doesn't make any sense. They aren't equipped to take risks in those large levels. There are other entities that are much more equipped to take risk than physicians, and I just question whether this makes sense. Some of the physicians who took risk back in the 90s when I started working for Medkai as a young lawyer, or were getting out of it in the end of the HMO era, it didn't work out too well for them. And frankly, we have other examples of other sectors of the healthcare segment that is in a better position to take risk who have had trouble with it. And it seems to me that risk should be left to insurance companies and to the federal government who are better at managing it. My second point is that we need to take into consideration the biggest risk for a physician is their time. And when a physician invests their time in a program like this and provides additional services, they are taking a risk because they have a choice. They could not participate in these programs. They could go do concierge or something else and simply do a lot more work and produce a lot more units and make more money. So there is no accounting for the risk of lost time in any of these programs or these documents. And I think that's a major flaw because that is the biggest risk. I think when Dr. Ryben was talking earlier about seeing 40 patients and not being able to see 40 patients, the reason you're not able to do that is because you're providing all these additional services. And how do we account for that risk? So it just seems to me that there's a little bit of a flaw here. And I know, again, I'm not naive. I understand why we are where we are, but I just wanted to express my reservations and concerns about the position that we're in.
Okay, thank you, Gene. Dr. Haft, any comment, or Dr. Reedman to this?
No, I think that it's a really important point. I think Howard's done a good job of kind of outlining a more reasonable program. You know, the other thing about the risk is that the risk has to be something that we can have, it has to be actionable and something we can have an impact on. I think that's a really critical point. Someone mentioned earlier about BMI and that we're measured by BMI. Well, I mentioned again, I've been doing medicine for 40 years. I don't think I've ever had a patient leave my office that I recall that was overweight that I didn't make some comment about or talk to them a significant amount of time about losing weight. But I only have so much influence there. And as everyone knows, it's great for me to discuss losing weight. I can document it, but the patient ultimately has to work on that. And if the patient doesn't lose the weight and the primary care physician's held responsible for that, you know, patient not losing weight, or held responsible, I'll give you guys another example that we were talking about responsibility and what we're responsible for. Well, I'm responsible for pharmacy costs too. And I had a patient of mine the other day, as a real life example, who came in who I've known for years and years, saw a specialist who put him at one time had an elevation of one of their blood levels, their triglyceride levels in this case, never had an issue before, slightly elevated. And they said, oh, you should take this medication, and came to see me because, you know, I know you, Dr. Reedman, I'd like your opinion before I start this medication. Well, the medicine they gave them was around $300 a month for something that most people just take over-the-counter fish oil for, which is a couple of dollars a month. And I didn't think the patient needed it for that purpose. But the point was is that that physician has no responsibility for the 20 or 30 prescriptions they write for this medication, which I don't think is appropriate in this case, that are $300, $400 a month, and most patients wouldn't question it. So I think, again, we're held responsible for that as a primary care physician for the cost of medicine, the cost of pharmacy, but the specialists aren't held for that to any accountability. And so the program that we've talked about this a number of times in different ways, the program needs to make not just the primary care physicians responsible, make us responsible for things that we can have action items on that we can control. But some of that responsibility has to go to the others that are in the program, whether specialists or hospitals or the patients. And I've said that before, but I think those are good examples. I think Gene brings up some good points along those lines, and Howard brings some good points up here. But again, I think anything we do has to be something the primary care physicians can have control over, and not something we can't control.
So thank you, Dr. Reedman. Other comments here, Dr. Berenson?
Well, This is a lot simpler than the one we reviewed a couple of weeks ago, and that's its merit. I think my view is the least amount of pay for performance this program can get away with, the better. But picking up a few of the comments, I think there are some measures and some conditions that primary care should do better in. And that is not, primary care doc can't control obesity without going through some probably adverse drug prescriptions and things like that. Primary care physicians can have a lot to do with diabetes control and with hypertension control. And as I've said a few times in this forum, I think there's a whole new science of managing hypertension. So I would, again, after year one, when we have to do some boring performance measure thing, we roll up our sleeves and try to build up some quality improvement projects as an alternative to just sort of sterile measurement of performance. I think there's real opportunities to actually improve care rather than just go through what seems to be just because CMMI says you got to have performance measures, and apparently I haven't heard it today, but the private plans also have measures that they have to be compatible with. Nobody has really seriously looked at the has concluded, but I think the literature does show that it doesn't work. It doesn't improve care. And so I think we should have as a long-term goal coming up with something better, which could also have a piece of that could be around reducing unnecessary costs. So I find this not very objectionable, but not very stimulating either.
Okay. Thank you, Dr. Berenson. Dr. Pham.
I look forward to this exercise. I do think that there's an opportunity here for us to reimagine a much more meaningful scorecard with some real meat in it. And I think performance risk is entirely different from insurance risk. I do think primary care can take on performance risk. And I think that if we pick the right measures, we actually have an opportunity to re-engineer care delivery. And by that, I mean, for example, one of Bob's earlier suggestions that I think is really a very direct way to engage primary care in system re-engineering is set explicit incentives for the use of high-value specialists and negative incentives for the use of low-value specialists. The same for facilities. I think in addition to some of the chronic conditions that Bob mentions, there's an opportunity here to think about smart processes that we want to ensure primary care is engaged in, whether that's care planning or mental health needs assessment or what have you. I think that there's, if we just migrate away from the usual standard measures and try not to address every body system in a scorecard, if we just really try to float to the top, what are the most generalizable metrics that reassure us primary care is actually thinking about its power to direct a prescribing pen, a referral pen, and do the things that nobody else in the system can do for that patient except primary care. I think this is doable, and I think this will be a fun exercise. Okay, I don't want to make it sound trivial. I don't want to trivialize Dr. Reben's life, but I think this could be an exciting exercise.
Okay, very good. Thank you. Jean, were you planning to make another point, and then Dr. Berenson?
No, I just lack the ability to lower my hand. I don't disagree with what Dr. Pham just said, but I will say that I think what you're talking about are incentives. And I think incentives are a good thing, and we should incentivize good behavior by people. I think we have to be careful when it's just over to large amounts of risk. And we have, in this country, created systems where doctors have taken unreasonable amounts of risk, and it's created problems. And I'm very nervous about this, and I'm nervous about a physicians' abilities to determine how much risk they're able and willing to take.
Thank you, Gene. Dr. Berenson, I think Ben had a comment.
Yeah, just two quick ones. I think in the context of if we actually do provide a substantial increase, even above Track 2, a meaningful, I don't know about substantial, but a meaningful increase in basic payment, and I agree with Dr. Pham that having a relatively modest amount of performance risk is a nice time to introduce it. So ultimately, they're going to be made better off than worse off than a new payment model. And the only other thing to say is I think it would be a great thing to do, but it would really take a lot of time to develop a real good program. People would really have to be committed to many meetings. There's lots of interaction with practicing docs. I think we could do just what Dr. Pham said, is coming up with a model that's not just the same old, but it really would be a major investment of time. And since time seems to be the commodity that's not in excess, to do it would really mean a major commitment.
Thank you, Dr. Berenson. Dr. Pham.
I apologize. I remembered the thought that got away, which is that I believe now that it is possible to either come up with kind of a global metric for comprehensiveness of primary care, or at least some proxy measures, right? Because that too is a key opportunity in system reengineering that we have here. God love the specialists, couldn't live without them, but each one of them has a hammer and sees that particular nail, whoever is presented to them. The more that care can happen before it requires subspecialty assessment, the better. And you know, we have migrated so far away from where historical primary care training prepared clinicians to do comprehensive care. I think there's a lot of room for us to kind of shift the system back to that world where we're not referring out for workups of dizziness because of time pressures or other things. If we are presenting a very healthy PMPM and other good performance incentives, we can make something like that explicit as a part of system reengineering.
So we have a couple hands. I do want to note the time. Dr. Riedman asked us to stay timely. Debbie, and then Dr. Haff, and then Melanie. And Debbie, you're muted.
Thanks. In the interest of time, I'll be real quick with just a couple thoughts. When we talk about power of referrals, I just want to remind everybody that we are in a Medicare fee-for-service arena here, and in our ACO experience, we found a lot of differences between when referrals were made and then where the patient ended up, because they can go wherever they want anywhere. So I think that gets a little dicey. The other thing in all this is we haven't really talked about behavioral health tonight, but a lot of the examples that were raised about, impact of primary care and the fact that primary care physicians can't do it all, I really feel to be successful, the state has got to continue to address the behavioral health access issues and the like.
Yeah, good point. Very good point. Dr. Haff, do you want to get a sort of a summary to see if that's the finger to the wind of the group in terms of the principles of the performance-based adjustments?
Yeah, so thank you very much, David. I just wanted also to let the advisory council know that among the discussions that we're having with CMMI is to continue the transfer of responsibilities year over year from the federal government to the state. That was as designed in the original Total Cost of Care contract, and pieces that we've progressively been taking more responsibility off of the plate of the CMMI and putting it in the state's coffers. Most of the educational program has shifted over to the state over the last 2 years, and we anticipate. We were asked, and we'll probably anticipate moving the performance adjustment adjudication and program to the state by 2023 when the track 3 comes into play. So to the very good comments of Dr. Pham and Dr. Berenson and others, this would be an important work that the state, the advisory council, probably an expanded version of that over the next years, would be looking at in a careful, thoughtful, and scientific way to find those very important, actionable measures that really resonate with what the goals are of the state, of the total cost of care contract, of the state's integrated health improvement strategy, and speak to what things primary care could and should and can do. Patient recorded outcome measures, some measures of patient engagement, things that have not been in the mix before. But that again is we're getting this very privileged opportunity for CMMI to say yes, you can do that, State of Maryland. You own this, so come up with good and better things. And I think that's really it is, as Dr. Pham said, a particular privilege to have the opportunity to do that. I just wanted to touch base again. I know we're running out of time. Just to make sure that at least the general framework of this model is something that people are not screaming and saying, no, we don't want to do that framework, because I want to be able to convey something to CMMI tomorrow.
Dr. Reedman, your thoughts on that?
I'm sorry, you echoed, David. I think what you asked, am I okay with it? I agree. I think that I think we're on the right track. I think we're all on the same page, and we're looking at it from I think appropriately different angles. That's why we have the people on the committee we have on the committee. But I think we're really making progress and heading into some more substantial discussions. And I again, as I have said before, these meetings, I walk away with a good feeling that we're heading in the right direction with it.
So there are two other hands. Do we, Dr. Reedman, okay to get the thoughts from Debbie Kuchka-Craig and Dr. Pham before Debbie saying no? Dr. Pham, was there a comment you wanted to make? And she may have just left her hand up. So we can wind down. We are just a couple of moments past the hour. If there aren't any concerns, Dr. Reedman, I would ask Melanie to make an operations comment and then see if our executive director, Ben, has any comments for the group.
Yeah, and David, I did just want to point out a chat that Jean put in there about the schedule for the meetings for the rest of the year. Because right now, all we have calendared is next week's meeting, which is the 8th. So I don't know if you or Dr. Reedman would like to comment on the schedule between now and the end of the year. But I also want to just tell everyone that there's going to be a high-level meeting summary and a video posted online similar to how we have done prior meetings. So David, I'll turn it back to you.
And I think we could talk about the scheduling and then get back to the group if that, Dr. Reedman, you're comfortable with that? Thank you. Ben, thoughts for the group? Comments?
Again, thank you all to the Advisory Council for joining us tonight. I think directionally we have some useful input to share with CMMI tomorrow, which is important. I think it's not likely to be the final step, but the first step. But please feel satisfied that we hope that the council would set some directions. And I think you have. It remains to be seen, how much enthusiasm we're going to hear from our partners in the federal government. But I think it's important to be hopeful but realistic. And again, a call out to Audrey and her team, David, and all of the staff at HCC, as well as Howard and Chad, the folks at the PMO. Believe me, they spend a lot of time planning these meetings, folks. So I hope it demonstrates the work that goes into these. And Dr. Reedman is always right there, a part of it, oftentimes breaking from seeing patients to get his input. So it's really a good team-based experience. And I think it's ultimately going to yield some benefit to the residents of the state as well as the primary care community.
Thank you, Ben. Dr. Reedman, take us home.
I'm good. Thanks everyone again. Thanks Ben for those comments, and I'll leave it at. I also want to thank everybody that's been here, in particular the people at the Maryland Health Commission. It has been a pleasure working with you guys over the last actually over a year now, and it has been a real pleasure working with the group of people that are there. They're passionate and they care about what they're doing, and I really appreciate the work that they do and working with them. So, talk to you all next week and have a good evening.
Thank you. Take care.